We'd like to ask the speakers to please come up to the table, Dr. Z, Dr. Johnson, and Dr. Watson. And then we are now going to have two discussants who are going to speak very briefly about their feedback on the talks that we've just heard. The first discussant is Dr. Uma Rao from the University of California at Irvine. She's a child psychiatrist, so she's going to give us a few comments, and I'll introduce the next discussant as soon as you finish. Dr. Rao, thank you very much. Nice to see you. Yeah.
Okay. I'm just going to be, have very brief time, so I'm going to be making just 1 point from each of the presenters for opening the discussion. Dr. Phyllis Z had talked particularly about the sleep being a multi-dimensional construct, but so far what most work that has been done is taking only one or two components of these multi-dimensional constructs. So I think it's really important for us moving forward in order to get a better or comprehensive view to do this multi-dimensional studies across various, both in different populations, different age groups, etc. Then coming to the next talk by Dana Johnson. Again, we understand that there are many individual differences in sleep. So in that component, she's particularly focused on racial ethnic disparities. This is still really an emerging field. And in particularly, we know a little bit more about behavioral components, but we know very little about the physiological components of sleep across these racial ethnic groups. And the little work that has been done also has been like they lumped all of the groups together. For example, Hispanic Latinos consist of multiple subgroups. Even African Americans, other work not in sleep has shown that those that have African descent versus those that have Caribbean descent differ in many different ways. So I think it's really important to think about understanding particularly the mechanisms of risk, as well as mechanisms of change when we are talking about interventions that she described. And also having larger subgroups of these different racial ethnic groups. Then the third component that Nathaniel Watson has brought about is, it's wonderful that now we have some tools that can have, that are ecologically valid, but still a lot of the instrumentation that's being used has not been validated. So we need to focus on validating this one. And if we can, at a population level, estimate this brain age, it would be really helpful for improving population health. Thank you very much, and hope to have a nice discussion.
Thank you very much. Okay, the next commenter is going to be Dr. Jakowski. Did I pronounce that properly? Diezenkowski, thank you. And she's the executive director of the Restless Legs Foundation. So you'll be talking about that. Thank you very much. Yeah.
Well, thank you. Well, good morning, and thank you for including the Restless Legs Syndrome Foundation in today's discussion on sleep disturbances in the CNS. Everyone at this conference and on Zoom understands the significant impact of sleep disorders on overall health, physical and mental well-being, and quality of life, a challenge that patients with an undiagnosed sleep disorder face in the primary health care system as a provider who lacks sleep education and a sleep disorder screening tool. Despite the severe impact of sleep disorders, the medical profession has failed to adequately prepare healthcare providers in the recognition and treatment of common sleep disorders. Educational institutions need to implement teaching of sleep disorders in their core curriculum. Training in sleep has long been siloed into specialty areas, yet sleep affects all biological functions. Ideally, sleep screening should occur at the primary healthcare level because that is the level where most people enter the healthcare system. However, our RLS Odyssey 2 study found a decade-long span between bothersome symptoms and proper diagnosis. Delay in diagnosis has long been documented in sleep disorders. Annual screening of patients for sleep disorders by medical providers will shorten delays to diagnosis and initiation of treatment, leading to better sleep disorder management and patient outcomes. A short sleep questionnaire at the primary care level would not overly burden the practitioner or the patient, but it would provide valuable information about a patient's sleep and referral to sleep medicine if indicated. Consumer technology devices are a secondary screening tool for healthcare providers to gain valuable insight about a patient's sleep. These devices measure a patient's biological functions and can aid in healthcare delivery, while minimizing impacts on sleep. Healthcare providers need to learn how such devices can be incorporated into their practice and their clinical assessment skills. New sleep research that focuses on strategies to prevent risk factors associated with sleep loss, such as hypertension, diabetes, cardiovascular disease, and obesity, is needed. These comorbid factors impact health-related quality of life and lead to further impacts on mental health, specifically depression and suicidal ideation. Our RLS Odyssey 2 found that a fourfold risk for depression and suicidal ideation in RLS patients when compared with the general population. We need more federal funding to support targeted sleep disorders research to address these issues. As the presentations in this session have shown, it's time to recognize sleep as an essential life function or even as a new vital sign, a measurable metric in the delivery of health care. As we raise the profile for sleep, let us acknowledge the importance of sleep as a change agent in health care delivery. Quality sleep plays an important role in our outlook on life, well-being, and even our level of happiness. Thank you for your attention.
Shall we start with questions from the audience? First, does anybody here, any of the participants, have a question? And could you please use your speakers?
Thank you. Thank you to all of the speakers.
Oh, I can-
If you use the mics on the side, please, just for the live stream so they can see you on the side. Right there. Thank you.
Thank you all. This is very stimulating. I want to start with Nate. So there are all these consumer products that are out there, but because they're consumer products, we can't see the raw data, the algorithms for analysis are proprietary. What do you see as a fix for that in terms of validating or comparing the Oura Watch versus the Fitbit versus the Apple Watch, et cetera, et cetera?
Yeah, great question. So Evan Chinoy in San Diego at the Naval Sleep Research Center has actually done a number of validation studies for some of these technologies that I mentioned, comparing it to actigraphy and to polysomnography, and it has found that it performs as well as actigraphy, if not better. So I think there is this general sense that we can just say, oh, these things aren't validated, but that's changing. So I'd encourage you to, read some of his work. I think, FDA approval for some of these devices, if and when they're ever accomplished, will be a big step forward. And then I think, we have to remove these walls between, we have to unsilo this thing and figure out ways for industry to work with academia in order to bring these technologies forward, in order to reveal all the things that all the opportunities we have to learn about sleep that right now we just can't really get at. So it's a challenge, I agree, but these discussions need to happen because this is the only way that we're really going to move things forward.
Oh, thanks. My question is also for you, Nate. So what are your, Percy Griffin, Alzheimer's Association. So what are your thoughts on some of these consumer technologies that incorporate some of the measurements into the bed itself, like the 8 sleep bed, so it gives the advantage of having contact but it does not disrupt the sleep. So what are your thoughts on that and how accurate they are?
Well, I think that, all these different beds and technologies have different strengths and weaknesses, and you probably don't have time to get into that right now, but certainly when you consider skilled nursing facilities and nursing homes, you consider people with dementing illnesses, having a bed as a medical device could be really helpful. I mean, you could look at bed presence, you can look at sleep and sleep architecture, sleep duration, and the bed hopefully it'd be like a telemetry unit in every hospital room or every room in the skilled nursing facility in order to understand, is somebody at their baseline? Are they deteriorating? Is somebody just out of their bed and at risk for a fall in the middle of the night, and you would know early enough to go intervene before the bad event happens. So I think that there's certainly lots of opportunities when we consider smart beds and the demented illnesses that are out there.
Hi, Dr. Hoganesh
Dr.
from Cincinnati Children's Hospital. This is sort of a question for both Dr. Watson and Dr. Johnson on the use of these consumer devices in minority populations. In Cincinnati, we have a large African-American population, and I don't know that I've ever seen anybody wear an Apple Watch heading into the sleep clinic. So I'm concerned that this may pass over entire communities.
Yeah, really good question. So one thing is we want to make sure we distinguish between race and SES, right? So it's probably more so a lower SES populations may be less likely, to wear these particular devices, which we know tend to also be, racial minorities, but it's probably more of a SES thing than race and separating that. And so I know in my studies, I use actigraphy, but we always supply the devices, so we don't have that issue with thinking about consumer technology, so things are always provided. But the other piece I want to mention is we did a lot of focus groups around devices, and people were very adamant about they didn't want to wear anything that looked like something was being monitored, tracked, and so on. So we showed them different devices, and it was the devices that looked more like a watch that they were more likely to wear. So for example, we were able to use the Philips Spectrum Plus, but they were not willing to wear like the GT3X because they're like, that looks like a device with, that they're measuring something. So I think what's important is understanding your population and, seeing what they need. And then also for sleep apnea, particularly, we go into the homes. We never bring them into the labs. All of my studies, we go to their homes and take the devices. So we address that transportation barrier.
Having done a sleep study recently myself, I would have called it a not sleep study. I barely slept at all.
Just one last comment. Some of these technologies, all they require is that you have a smartphone. And you can download the app, and there's a free element to it that you can monitor your sleep. So it's some of them are extremely accessible.
Speak there. We're focusing on sleep, monitoring sleep, but I think it's really important to think of this as a 24-hour issue. So we have to monitor wake activity because what's happening during the day, wake, affects your sleep. So when we talk about sensor technology and sensors, I would think about that as another, one thing is to monitor sleep and breathing, but how you breathe during the day probably affects how you're going to breathe at night as well. So just something to keep in mind.
Go ahead.
Yeah, Isabel Curro. I'm from Cohen Veterans Bioscience. Kind of building off the last question, because that was kind of my question as well. But how do you guys, Dr. Watson and Johnson, kind of look at the general mistrust of the amount of data being collected historically, obviously for certain populations, but also in terms of data privacy? Is any comments on that?
That's a great question. You know, there was an earthquake in the Napa Valley about 10 years ago, and there's a device called Jawbone Up that's not around anymore. And they basically looked at how far away you were from the epicenter and whether or not you went back to sleep that night for an earthquake that happened in the middle of the night. And they have a really beautiful figure. It shows the closer you were, you know, the harder you shook, the less likely you were to go back to bed. Really cool, but it makes you wonder, when you bought the device, did you agree to be involved in kind of this type of research? I think, we just, we have to just be right up front about the data and just, we need to be sure to let people know that really we're only interested in monitoring sleep, and then, have data protections in place, and then I guess people can make their choices from that point going forward. But I find, those of us that are older are more concerned about this. Younger generations want to share everything with everyone all the time. So we'll see.
Thank you. My name is Michael Torrey. I'm with the Alliance of Sleep Apnea Partners. I think the presentations this morning have presented an immense case that sleep deficiency is affecting every thread of our society. Not just, you listed many examples. And I think the general public must be aware of this because, as Nate pointed out, and there's other sources, tens of billions of dollars are being spent people seeking remedies every year. So that juxtaposed with another comment that seems to be a recurring theme this morning, and that was, well, we don't know this and we don't know that. We don't know enough. And so my question to the panel for discussion would be, what would be a finding that turns the corner on this discussion? Or is there any such point of threshold for accepting recognition of the problem?
Kathleen said I should take it. So I listened to her. I think, Michael, you bring up the point that it's we tend to think about, we don't know enough. We need something perfect. And do we really need that? And when should we start? I think the time is now. And I think we have enough evidence, like you said, that very persuasive, that sleep and circadian health are really, really important for all aspects. How do we measure it? I think we should come to some consensus. As imperfect as it may be, we come to a consensus. Things can change over time as technology develops, but I think we need to figure out what are the minimum criteria. We don't have to be the perfect. What's the minimum stuff that we need to measure in sleep, in wake, physical activity, meals, nutrition? What's the minimum? And then everything else can be, BMWs after that, right? But I think that's where the field can do that right now, is to come to that type of consensus. And I urge, whether in this forum or the NIH or others, to really think about putting this type of workshop together. I think we can do it today.
Great question. Just, I would say for these newer technologies, medical decision-making that is made based on these technologies, we need to show that it improves outcomes for people. And once we've climbed that mountain, then I think, that's basically where we turn the corner.
We have to decide which ones we're going to use to do these clinical trials. I think the problem is the lack of clinical trials, but it's really also the lack of consensus of measurements.
So if I can have one short follow-up to that, and that is, so something needs to be done. Is there any profession in the United States, medical profession or research profession, that is taking the lead in that discussion? Or is that just being left to all parties generally?
Michael, I'd like to take that question.
Okay.
We actually, some of us in this room, attended the Sleep Advocacy Forum last week, and we learned from the American Heart Association that they're saying sleep is part of the Essential 8 now. So they're taking a lead on this, and I think that, in this room, we have enough brain power. As Phyllis is saying, we need to change this discussion and take the lead here.
Thank you.
Hi.
I'm Dara Minowick from Harvard Medical School and MGH, and I just wanted to note that actigraphy and polysomnography provide different and very complementary information. They don't replace each other. And I just also wanted to share a cautionary tale from schizophrenia, where we had patients with schizophrenia and healthy people in the hospital for overnights with both polysomnography and actigraphy. And while the actigraphy was very accurate in healthy people in showing when sleep occurred, it was very inaccurate in patients with schizophrenia who would lie in bed motionless for a very long time watching TV. So I think we just have to be very careful about how we use these to measure sleep and really validate them in the populations of interest.
Yes. Thank you. That's an important comment. Let's
Hi,
go to this side.
I'm Tracy Madsen. I'm from Brown. I'm an emergency medicine physician and epidemiologist. I have a question for Dr. Johnson about some of the interventions that have been developed up to this point. Have there been successful interventions that address some of these logistical challenges, especially for individuals that have poor sleep duration due to multiple jobs, as you mentioned, or shift work, or other types of work that may be more common in communities where the socioeconomic status is lower?
So if you could just expand, what do you mean by logistics?
Right, so I guess if you're designing an intervention for individuals who are working 2 or 3 jobs, how do you get around those challenges when they have to work 2 or 3 jobs to make ends meet?
Yeah, no, that's a good question. I'm not familiar with any interventions that have targeted that. If we look outside of sleep, there are more, particularly among economists, where they do financial interventions. But again, I think in terms of sleep, we're a little behind in terms of developing our sleep disparities interventions. But I think we can learn a lot from those other fields and be able to, apply them. Now, what we have seen more recently with sleep interventions is more so the tailoring of developing culturally tailored interventions. And then instead of, so for example, some interventions that we have in my group where we are using apps that allow the participant at their own, when the time is convenient for them to use, to tackle some of the stressors that may emerge throughout their day. So we have a stress reduction app. So if they have a stressor that occurs, whether they're at work or at home, be able to use that, and we're seeing how that improves sleep. And so we're not explicitly, tackling, the issue of multiple jobs, but thinking about how these factors that they encounter contributes to stress, and then how we reduce that is more so what we're doing.
Thank you.
I think the sleep IQ of the country is low, and I'd love to see sleep education in elementary schools across the country. You can spend 15 minutes on it, and I think have a huge impact on duration, not having lights on, things like that.
Yeah, Stroll, Case Western Reserve University. So I want to drag it back to biology and evolution. The biology is that we have basic science that we heard about before that we have to map onto humans, where in the networks they are, and are there particular things that the basic scientists can point to that the clinicians can find oddities or genetic defects or other things that could illuminate how sleep and circadian rhythm interact. And I think that's just one example. The other is the idea of evolution. I particularly am a Darwinian medicine person, is that these symptoms are expressed because we learn how to express them. And I think the stress paradigm of cell and that particular paradigm is very important, and think of that for functional disorders, chronic fatigue syndrome, post-COVID syndrome. All these things have a sleep component to it, and the common element of that is stress. And I think we need to sort of think of that. And then the other thing in evolution is we study Tibetans just because it's hypoxia. They sleep very well now. So we have to get some very good sleeping populations and then say what happens. And finally, development. most of the ontogeny of sleep work to me seems to then get interpreted from an adult perspective. I think the ontogeny of sleep in utero and in early years has a dimension to it that is not, I'm dreaming of wild bears when I'm 45. That's not it. It's something there, and I think it's growth and development, as other people have mentioned. And I just think that we
Very
need to
important.
drag that back to the major research themes that we have. And then the clinical expression is what Dr. Nathan just said. What is the outcome of these things? Not just buy them, but what is the outcome?
And learning about development is going to be very important as the future, as we've heard in terms of the CNS disorders, for example, and their overlap.
Brian Fisk with the Michael J. Fox Foundation. I was kind of fascinated by this use of sleep architecture for brain aging measurement, so two questions, I guess, related to that. One, any data on correlation of a sleep-based measure of biological age with other biological aging measures like epigenetics or things like that? I'm curious if you could comment on that. And second, how consistent over time is a measure like that? Do you see people who tend to be biologically older than their chronological age tend to stay that, or does that change over time? Do you see a lot of variability in that measure?
Thanks for that question. The first part, I think there's not much out there to comment on. The second part's very important because we would all like to hope that your brain age measure can improve if you improve your health or if you get treatment for a neurological disease. We'd like to think that it's malleable in a positive way and that all roads don't point towards increased dysfunction and disease. But I don't believe that that's been established at this point. We're really at the point where we're showing that we can measure it, that it's stable, and that increased brain age is associated with disease processes. And then, I think that's a crucially important question, and certainly the way that we would like to use it if we consider it a vital sign for brain health.
Tom Scammell from Harvard
Yeah.
Medical School. So on the question of devices and so forth, I think the different devices are sometimes built for different purposes, whether it's monitoring movement or screening for sleep apnea. But one question that comes up in clinic pretty frequently from patients with periodic limb movements is, how can we look at a therapeutic response other than the quality of their sleep? And I'm just curious if you guys have any comments on monitoring leg movements per se, either before sleep or during sleep.
It's a great question, and I would say, most of these devices have a summary measure that would attempt to include all the things that Phyllis talked about that are necessary for healthy sleep. It can be considered a sleep quality measure at the end of the day, and so certainly in somebody with restless leg syndrome, 80% are going to have periodic limb movement disorder or periodic limb movements in sleep. That would be seen with these devices that would result in a lower score, and then so I think that it's really at a point where if the scores remain low and then you try to intervene and things aren't getting better, that gives a clue to the patient that there might be a clinical sleep problem present to bring it to somebody like you in clinic. But right now it's not specific enough, or the devices that I've seen, to say, oh, well, this amount of restlessness in bed was related to restless leg syndrome as opposed to the sleep disruption of obstructive sleep apnea or narcolepsy or other diseases. So it's pretty nonspecific at this point.
So PLMs were actually validated, with the actigraphy on the, on the shin in the Iceland study where they discovered the genes, right? It's really mainly through actigraphy. So you can actually do that, and it is rhythmic. You can see that pattern, and it correlates very nicely with the PSG recorded anterior tibialis muscle activity. So I guess you could put any of these potentially activity or motor activity monitors on the legs and be able to do that. I've
Yeah,
done that.
I was wondering if like the
clinically.
mattresses and so forth,
What?
where you're measuring, where you can actually measure multiple limb movements simultaneously. If anybody's really sort of pursued this, I have a
Mattress,
couple.
yeah.
I have a couple of patients who are engineers with periodic limb movements, and they've hacked together various things themselves.
Maybe mattress, maybe movement
Yeah.
from the mattress. You may be able to look that. You may not know exactly where it's always coming from, but if you have it mapped well enough, you may be able to look at the legs. Because you have limb movements, you have other limb movements too. You have arm movements as well, so.
Are you doing visuals as well, or are you just doing pure, looking at
I'm
instrumentation?
I'm looking for your ideas, but I
Because you really have to do both, and I'll tell you, I have a kid with RLS, and they, the leg counts, when I took her to a pediatric expert, and they did this PSG, it was much different than what I had done before, because, I'm a nurse by training, so I got to stay up and watch that. And see how they did it in the lab, because it's really important to have somebody that, skilled professional who's watching, but not just looking at the machine itself. You may miss something.
Okay, so I think our time is up. Was there one more? Did you have a question? One more?
I think he was before me.
Is that it? Okay.
Okay. Go ahead. Okay. Yeah. So, hello everyone. My name is Solomon Ayalu. I'm from the Congressional Black Caucus Foundation. And my question is directed more so to Dr. Dana Johnson here, and this is welcome to everyone else on the table as well. I was just wondering if you could speak to the importance of understanding the history of sleep disparities in disadvantaged communities. For example, many people do not know about Samuel Cartwright and the impact he has had with his pseudoscientific theories on the current state of sleep disparities. So I just want to know from your perspective, is the history of sleep disparities important to address as we look to combat sleep disparities in Black communities and other disadvantaged communities?
Yes, so I'll try and keep my response brief. But this past sleep conference, we had the first structural racism session, and we had a historian that was on the panel, Ben Rees, who wrote the book Wild Nights. And so in there, he talks about the context of where particularly stigma around sleep comes from. And so to directly answer your question, yes, I think the history is important. And so slavery particularly was a movement in which sleep was penalized, and that's really where we think the stigma came from. And we can even see at present day where lower SES populations are often told that and this was actually on a popular TV show, that they're poor because they sleep too much, which we know is not correct, right? And so, but a lot of this has generational roots where the stigma continues to persist. And so we have to think about the root of that in order to address it and be able to move forward.
Thank you.
Okay, well, thank you very much. So I think this session should end. I think there's two topics that I think we covered that are going to be picked up in all the other sessions throughout the meeting. One is sleep needs to be central to our health system and health care. Secondly, we really need to resolve some of these issues about how we measure it. And particularly, it's the biggest challenge to translational medicine is how do we build on the basic science and have common measures across the different species, both in the clinic and community. So thank you very much. I look forward to the next session.
Thank you so much to Kathleen and to the panel. We are going to break. We will reconvene at 11:40 back here. So for those that are joining us on Zoom, please join us again at 11:40, and Louis is going to moderate our next session.